Let's Talk About Pain, a podcast from the Quebec Pain Research Network. In each episode, we discuss the latest advances in pain research with guests from across Quebec in the health and research communities. Enjoy your listening. Okay, so we're back on the podcast right now, and sitting with us now is we have both Dr. Alberts and Rachael together to sort of come together and sort of chat with things as a group. So I think some of the first things that we're going to sort of be opening the floor to sort of everybody's questions and go from there. But the first thing that, sort of came to mind for me, at least, was Rachael. You mentioned you had a lot of pain, a lot of complex pain, chronic pain, a lot of stuff with that. Nicole, sort of in your research and clinical expertise, what are some things that you see missing in sort of that type of care, and what would sort of be the recommended care? What does the literature tell us about sort of chronic pain, complex pain? What's the sort of evidence-based interventions?
Yeah, so just based on kind of what Rachael was describing earlier, it sounds like she has, a combination of different kinds of pain conditions potentially going on, and that have started maybe at different stages, with the low back pain, not too long after cancer treatment ended, migraines developing a little bit later on, some joint pain. So I think it's a really kind of almost good illustration just to say of when we're talking about how complex the chronic pain picture can be for people when they're on treatment and then when they end cancer treatment. This is exactly what we're kind of talking about, other health conditions coming into play. It is complex. In describing, and I thank Rachael for being so open and honest in describing her experiences, with cancer care and in the, pain management area. She highlights some things where, maybe that pain was assessed, but then like she mentioned, potentially not really followed up on a ton. So even in, the maybe clinician saying, okay, it's psychosomatic. That tends not to be a term we use so much now. We try to, frame that in a different way and kind of more so in the realm of like psychological factors, right? How we think about pain, how we're feeling. We know they can play a role in your pain experience. But there's also other factors that can influence it too. Social factors, medical, biological factors, likely your cancer treatments, that sort of thing as well. So when we're talking with patients in the clinic about kind of where that pain may stem from or trying to kind of conceptualize it with them, we often try to pull in those pieces, which then really kind of nicely feeds into actually how, we want to treat chronic pain. And the kind of, gold standard approach, evidence-based approach we go to for chronic pain is that what we call like a multimodal, kind of multidisciplinary approach. So we find that when we hit, the chronic pain at kind of a variety of different angles, and the combination of what we hit it with is going to be different for every person, but usually it's a combination of something like, working with a pain psychologist, working maybe with physiotherapy, occupational therapy. It could be doing something like massage, working with a pain physician as well, someone who's a specialist in pain medicine. So it's really this combination, and ideally all those healthcare providers are also talking to each other. So they're really, tackling it from the same place. We realize too, in rural kind of remote areas, you might not always have access to that sort of kind of full-fledged pain team or clinic, but then we're trying to kind of build one, right? So you're still kind of tapping these areas. Hopefully those providers can connect with each other. So yeah, that is kind of, once, if we recognize that that chronic pain exists and maybe in a few different locations, that we're kind of leaning towards that multimodal, kind of multidisciplinary approach is usually the ideal way to tackle
Right.
it.
I think too, one thing that sort of stood out in terms of Rachel's story is, it's not even that she's in a rural place. She's in Toronto, which is supposed to be one of the hubs in Canada, at least for medicine, with a lot of academic institutions. And even there, in a place where we think these things, services would be available, seems to be, a lot of struggle just to get the appropriate referrals and to have people connect with each other. So I thought that was really interesting. And then Rachel,
It's
yeah, Rachel, please add.
it's a huge struggle as a patient. If you have multiple providers across multiple hospitals, you're basically having to be your own patient care coordinator, and that's a full-time job. Oh my god, just trying to call some of the clinics to actually get through to talk to somebody, you need you need a full-time job, but no one's paying you to be your own patient care coordinator. And the biggest issue is the lack of universal electronic medical records. So even on University Avenue, Hospital Row, half of them can't access stuff from the next hospital next door. And that's really problematic.
Yeah. And then so Rachel too, sort of on your side again. So if they don't have that universal record, and you're going to different institutions, what do they expect for you to know? Like, how detailed do they want your history? How much do they want to know from you? Do they require you that you bring your records? How does that look like?
So I've never been asked to provide, like, a digital record or anything like that, but they go through a history. Every new doctor you see is gonna ask you for a history. Half the time, will ask you for another history next time to see you, or you get a resident who comes through who's gonna do your history again, and they want the full thing. They want me to remember a full 18 years of medical treatments, of surgeries, of what chemotherapies I've had, what this, that, what drugs I'm on, what drugs I'm not on, what drugs I've been on, and it's a lot. It's a lot for anybody. And luckily, my parents were really on top of everything, so they know all that little stuff in the years that I don't remember what exactly was going on, and so I'm so thankful to them for that because if they weren't, which, if you're a parent of a child with cancer, there's a lot going on. It is a terrible experience, and it's warranted that you're gonna forget something. So, to ask you for 18 years of history that's not documented anywhere except in the patient's brain is ridiculous. It's 2023. We're supposed to have one of the best medical systems supposedly in the world. Where is that connection between one hospital from the next hospital? I should be able to go from Toronto to Sudbury, and they can see, "Oh, this is everything you've had done,"
Hmm. No, it's a great point.
and that doesn't exist.
Yeah, I think that's a great point of especially stuff that's missing. And I don't think that's a problem, again, unique to Ontario, but I know also in other provinces, that's also sort of a big issue, especially not having any type of unified provincial medical record. So yeah, that's a lot. Rachel, the thing, another question that I had in mind too, sort of when you were speaking is, again, you've had a lot of these painful conditions, you have a lot of pain, you have a lot of history though of, sometimes that pain, meaning really significant things. When you do experience pain, what sort of goes through your mind, I guess, and how does that play out?
Oh, yeah. It's having the chronic pain is one thing, you're like, "Yep, that seems normal," but even in the back of your head, you're like, "Is that normal? Does that hurt a slightly more today, or doesn't it?" And then especially the headaches as well, like, I have migraines. Thankfully, I have brain MRIs every year because, again, of this genetic condition I have, I am susceptible, ooh, to brain tumors. And so that is a little safety blanket for me, is to have, "Okay, I have these MRIs every year, so I know, okay, I'm covered." But there's still always a little issue that is like, that weird pain is definitely a tumor. And I guess a good example of that is that I moved to England in September for a master's degree, and this was like, I was excited to have a break from managing my healthcare woes, and I was like, "This is gonna be awesome. I'm not running downtown all the time for scans and blood work and this and that." But the other side of that coin is, "Oh, I've got a weird pain," and I'm like, "Oh my god, I haven't had a brain MRI in 8 months. I might have a brain tumor now." And the whole cancer experience really turns you forever into, like, a hypochondriac, and it's an experience that I've spoken about with other of my friends who are cancer survivors as well. You will never get over that.
Right, right. Again, that's just so incredibly tough. That's so tough. And Nicole, to follow up with that, is this something that comes up in the literature or sort of in your clinical practice? It seems like it is relevant to a lot of survivors. How does that typically, manifest almost? Or is there a clinical term
Yeah.
for it, I guess, too?
Yeah, I mean, what Rachel's describing, I mean, we definitely see it come up like clinically and talking to patients. And, there's some of it in the literature, but yeah, that kind of fine line you have to sort of walk or balance, I think, as a survivor, where, like Rachel's describing, on one hand, you kind of have to pay attention to some of these things, right? You can't like block it out completely. Or maybe you just are more aware because in the past, pain has signaled some not so great types of things. Sometimes it's not meant, harm or anything like that, or been a sign of something bigger. But as a survivor, you're at risk for, potentially cancer coming back or another, condition developing. So it's that balance of like, wanting and trying to be, as we would encourage people to be, like engaged in their follow-up care, right? Going for the appropriate scans and seeing your doctor, doing all the things you need to be doing. But also trying to decipher day to day, okay, what is this new pain that's coming up? Do I kind of monitor it and then decide what to do with it? Do I brush it aside or think like, okay, no, it's related to something else? So yeah, I think that kind of, I don't want to say internal struggle, but trying to balance those two sides of the coin, is I think a pretty common experience.
Rachel, what do you sort of take of that, I guess, hearing more of sort of a researcher clinical viewpoint as more of coming it from a patient side? And you touched on a lot of it, but anything else to add?
Absolutely, yeah. I think, yeah, it's definitely a different experience being a cancer patient or prior cancer patient, versus someone who has just suddenly developed pain. It's very it you can't generalize a pain experience. There's, like, different groups of people who have different types of pain, and, the cancer group has maybe different pain than the people who've developed it separately, and even within the cancer group, everybody's having a different kind of experience with that. So, again, that's why the research is so complex, and sometimes it's so hard to do something with that, but that's also why patient partners are so important.
Mm. No, for sure. Yeah, I think sort of as we're winding down, I think there was a lot of sort of interesting conversations that we had. Again, sort of mixing the practical experience of sort of patients as well as sort of how some things are viewed in more research and academic terms. I think a lot of interesting stuff, and again, a lot of interesting things that can be learned, through the academic side by taking a more patient partner approach, just see that as just, such a strength and benefit of research, because at the end of the day, we're not helping people, sort of what's the point, I guess, to a lot of this stuff that we do. So I think that's a really, really nice thing in working with patient partners. So I think that sort of wraps everything up with today's podcast. I want to thank Rachael and Dr. Alberts for joining me today and discussing more about pain during cancer survivorship. It's been really great. And we'll see you on the next one. Thank you for listening to Let's Talk About Pain. Don't hesitate to subscribe so you don't miss an episode, and to share the podcast with your friends. For more information, visit our website at qprn.ca or our YouTube channel by searching Quebec Pain Research Network. See you next time.